Right, tonight we're going to be talking about integrative approaches to cancer. Some of the things I've aimed to do tonight, we will not achieve in a million years. I've got so many things I want to tell you, and we've only got 2 hours, so it's not going to be happening, but we'll get through as much as we possibly can. I run Cancer Options. Yeah, I run Cancer Options, and have been doing that for about 20 years. We're an independent consultancy. My background is actually, I used to be an oncology nurse for many years, dispensing chemotherapy and working palliative care as well. And so an awful lot of people go through the cancer system and go through that process. And I really got into this field quite simply because I couldn't answer anyone's questions. So people used to come into the oncology clinic and, you know, they'd ask questions about how can I look after myself, what can I eat, what can I do to support myself, and then I just have the chemotherapy. And not much has changed in that field, to be quite honest. And we had a very bad attitude towards anyone doing what we now call integrated medicine. In those days, what we call alternative medicine. And we'd have a good laugh in the staff room at them and think it was utterly pointless. And it wasn't until I really began to get to know some of my patients who were actually helping themselves and, you know, had a real interest in supporting themselves. And one lady in particular I remember, and, you know, this is 20 years ago now, but Gillian, she was fabulous. She had bowel cancer, liver mets, stage 4, and she was actually working in London, and she lived at Nottingham area. She worked in London, and she came up to us every 3 weeks to us in Nottingham to have her chemotherapy. And she would bound through the door, full of life, full of energy, and far more energy than I had. And I got to know that she was doing, you know, a good diet. She was doing vitamin C. She was, you know, looking after herself and under the care of a doctor in London. And I thought, right, okay, well, she is certainly, you know, doing a tremendous amount of good work. And her survival was tremendous. Absolutely. I remember distinctly, I'll never forget this, standing outside her room with the oncologist. And the oncologist was looking at the CT scans. And he's going, look at this, Patricia. It's my best ever patient. I go, yeah, you're brilliant, aren't you? Yeah, you're great. And she did. She survived long. She survived very well. And that's why I began to think, well, maybe we're not the clever ones. And, you know, began to look into this. So it's been a fascinating and frustrating and exhausting journey, to be quite honest. What's fantastic now for me, from my point of view, is a lot of in those days there was some quite cranky stuff going off, some quite left-wing stuff, but now the science is coming through, the knowledge is coming through, and, you know, we can now validate most of the things that we do, and there's an awful lot of interest in it. But the biggest thing for me now, really, to be honest, is back in those days, I would kind of, if I got a client come to me, I'd have to kind of try and sell to them why they should follow an integrative path, why doctors don't understand it, why this, why that, and, you know, really a lot of explanation on why the benefits are there. Nowadays, I don't have to. Most of the time, people come along very, very well informed. They're on board already. This is what they want. And, you know, one of the things I really want to get across to you tonight is that, you know, you really, working with people with cancer, it's one of the most fascinating areas because when you see the benefits that people have, it's interesting, it's rewarding, it's all those things. But I know a lot of the time that nutritional therapists get put off working with people with cancer. And you really, really shouldn't. You really shouldn't, especially by the medical profession who don't understand or know what they're talking about when it comes to our field, because it is our field. And, you know, if anyone is sort of getting put off, oh, you know, they mustn't do this, they mustn't do that, you know, show me your research. Show me your research base. Raw Mars bar, tell me why filling somebody full of sugar with cancer is a good idea. Where's your research to support it? So, you know, hopefully, you know, we'll be able to show that it's a tremendous field. People with cancer not only need good integrative support, they want it. And they're not getting it at the moment. They haven't been getting it for the past 20 years. But around the world, things have improved tremendously. In America, Most of the big cancer hospitals now have integrative wings. They have research departments for integrative medicine. They're doing tons of studies. And, you know, it's as if in the UK, our doctors live in a little bubble. They don't realise what's going off, and neither are they going to take the interest. I spoke at a conference in London about 6 weeks ago. It was a 2-day integrative conference. And I was doing some of the... I knew there was going to be some doctors there, so I kind of made sure I had loads of good research, and I was presenting all the latest evidence for integrative care. And in the room where they have all the exhibitors, there was some people from Christie's Cancer Hospital in Manchester, so I thought, great. And it would have been great if they'd actually bothered to come out of the room and come into the lecture, and they didn't. They stayed in their blinking room. And then they turn around and say to us, oh, but you've got no evidence. So actually you have. You haven't actually come across here and listened to it, have you? So they will. So I'm not going to ramble on endlessly and try and cram as much in as I can. So what we're going to try and cover, looking at cancer metabolisation, which it's a growing field, research is growing. I don't have all the answers, by sure, but it's... we're learning so much about cancer nowadays and how it behaves. It gives us lots of opportunity to support. What the aims of the integrative support are. Hopefully look at chemotherapy, radiotherapy support, and anything I talk about, supplements, stuff like that, it's not an inexhaustive list. There's always more things that I'm sure you know about that are also good, so it's not, it's not supposed to be definitive. I'm going to have a couple of looks at some differences between, for example, breast cancer with hormonal cancer and triple negative cancer, and functional testing, where that fits in. If we get chance, we'll cover cachexia, which is the wasting disease, which is one of my favourite subjects. And let me stand still a bit. All over the place. All right. And also cervical cancer and HPV. We haven't got a chance to get into that one, but we'll have a go. Okay, so the main aims of integrative support is to support the body in dealing with cancer cells and to repair the contributory elements and maximise the cellular function for people. And we do this via things like immune stimulation and modulation. Sometimes you need to modulate the immune system rather than just stimulate it. Chelation I will cover in detail because it's very important with angiogenesis. Methylation, detoxification, genetic upgrade that can occur when cellular change takes place, and anti-inflammatories. And there's a lot of things that you're more expert than I am on, I'm sure, on things like liver detoxification and gut and things like that. So I'm not going to go into a great deal of detail. I'm sure you know a lot about that already. So we're getting a lot of new insights into how cancer cells behave and how cancer is very much a self-perpetuating process in the body with a lot of interaction and communication. And some of the things that we'll touch on as we go through is that recent discoveries that pancreatic cancer cells are immune to starvation, prostate cells and leukemias metabolize fats as well as sugars, and cancer cells can convert cholesterol to estrogen, and cholesterol's a devil with the immune system. Lipid metabolization is disrupted when people are losing weight. And, squamous cell carcinomas do not metabolize glucose. We're going to learn an awful lot more over the coming years about how each individual cancer, as a generalization, metabolizes and performs, etc. So, this will all be added onto, but, always the case, we work with what we've got at the time. So the real important thing when you're trying to help somebody influence their outcome is looking at what we call the extracellular environment. And the extracellular environment is the environment around a tumour, the environment where cancer cells meet normal cells. And that is an environment where there's a lot of interaction going on between your normal body cells and the cancer cells. And this is the area that we really focus on to get good responses from treatment and good recovery, because it's so important. I often think, personally, I think, chemotherapy and radiotherapy, if they're used, they're only the first step, and one of the less important ones. What happens after treatment is actually vitally important for people. And cancer cells are interactive, so they actively recruit what they need, And so they will extend cables out and grab cells in, and when they pull them in, they can alter their own survival instructions and develop ways of developing their own blood supply. So there's an awful lot of interactions going on there. And they will pull in immune cells, healthy cells, inflammatory cells, fibroblasts. There's only about 5% of cancer cells needed to form a tumour. So it's interesting with tumours because everybody gets very worked up about, oh, it's a small tumour, it was a big tumour. Size is unimportant in this issue. And actually in a tumour there's only going to be very small, that's actually active cancer cells. You'll have a lot of other cells, you'll have a lot of metabolism, a lot of debris. And you'll have a lot of dead tissue as well if the cancer cells are being dealt with. So, I mean, as an example, hormonal breast cancer is a very inflammatory. It's not inflammatory breast cancer, that's a different cancer, but it's quite an inflammatory cancer. And you'll often get women who come along and they sort of say, okay, I found this big lump in my breast. It wasn't there a month ago. And it wasn't. It's nearly all inflammation. It's just had a massive inflammatory reaction. And then you get somebody else say, it's only a very small tumour. And they sometimes can be the ones to worry about more than the big ones. So, and cancer cells, when they're spread around the body, they're actually, cancer's ability to mutate and develop the ability to survive in the body is bordering on admirable, really. It's looking at its environment all the time and taking from it what it needs. So, for example, when cells are travelling around the body, if they meet a tight space, that tumour will come out into cells will come out into single file, and they'll go through that tight space, and they'll get to the other side, they'll clump back together again. You don't even see that on the London Underground, do you? You know. Yeah, quite. So there's it's a remarkable thing in many ways. And this is a breast tumour cell, and as you can see from that, all the little spikes that are going out there, to pull in everything that it's needed into that cell to make it into that tumour. And we then have what we call, this can develop into cancer's living shield. So what happens when you have a tumour, and there's cancers are different. Some cancers can be metabolically quite dormant. Sorry. What was I doing that? Right, some cancers can be metabolically quite dormant, and they won't be doing an awful lot of metabolizing and interacting. Others can be much more active and much more interactive. And so when they sell that cellular signaling out, what cancer cells are doing and tumours are doing is they are metabolizing in glucose, and they convert that into lactic acid. And they then, an ideal situation for a tumour is to surround itself with inflammation and a very low oxygenated environment. That makes for a very happy tumour. So that not only allows the cells inside not to be affected by treatments and chemotherapies, but it also blocks the access of the immune cells. So when people's immune systems, it gets complicated. There's different pathways that cancer uses, like PD-L1 pathways, to block. But essentially, what they are doing is that the immune system, if it's active at all, will be trying to sort things out. But where you have inflammation, that actually blocks the immune cells from getting in. So the cellular signals. Sorry, let me switch that. The cellular signals that were coming in, and the cellular signals that are coming in are going to try and get to the cancer cells. Where there's inflammation, that's blocked, a bit like a radio signal. It literally scrambles the signal. And of course, as we know, inflammation has a lot to do with cancer, and every cancer treatment that the orthodox side uses causes inflammation. So it's a paradox that it's actually enhancing the development of that. So cancer's living shield is really the aim to get. If you can affect that, people can get better results, and we affect that by lots of things: by diet, by fasting, by anti-inflammatories, by oxygen. All these things we're going to talk about. And actually, around the world, I think one of the places I see the best results at breaking this down is actually in Istanbul. The clinic there does some fantastic work on doing that, and when they do that, they actually just use chemo at 60% of its normal dose, and they get much, much better results. So, and one of the other problems, of course, is we don't get to the stem cells with our, radiotherapy and chemotherapy. And stem cells are very important. We have a tiny, tiny population of stem cells when it comes to cancer, and these are the ones that stem cells will hide in the body where there's most inflammation, and where these are the ones that can self-renew and come back, and you can knock circulating cancer cells out with cancer treatments, but if the stem cells stay there, there's always a possibility that they can come back and renew themselves and regenerate again. And it doesn't take, that can be any period of time, from a small amount of time to a very long period of time. And of course, chemotherapy doesn't get to there, and there isn't a treatment on the orthodox side at the moment that does, but lots of different natural compounds can get to stem cells. Vitamin D gets to stem cells, curcumin, I believe grapeseed does as well. There's lots of things that we can use that will actually help to finish the job off for them. And curcumin, of course, obviously everyone knows curcumin. It has many, many different properties. It's one of the most valuable things with cancer. It suppresses cytokines, and interleukins are very important with cancer. Interleukins promote inflammation. So anything that gets to them is a very good thing indeed. Hello? Have we gone on to the... that was my fault. Sorry, I'll press the button down there. Thank you. Yep, sorry. Resveratrol, quercetin, equally, lots of polyphenols will get to stem cells and take them out alongside it. So the nutrients in the environment are vitally important, and they're critical to affect that genetic mutation. So for the cells to stay healthy or to recover quickly from chemotherapy or radiotherapy, they need a high degree of gut nutrients. They need the correct pH, lack of oxidative stress, lots of oxygen. And of course, for the average person going through chemotherapy in the UK, they're told, okay, you're going to have the chemotherapy. It doesn't matter what you eat. It varies from hospital. I don't want to be unfair. They're all getting better at it. Some of them even say, leave your Mars bars at home. I don't know. But largely they're largely told that there's no evidence for it. And I even heard yesterday, somebody on the phone yesterday, was in the office, and someone said, oh, my oncologist said, don't take antioxidants with cancer. They're harmful. I said, okay. That's shocking, aren't they? Yeah. You ever see anyone have cisplatin chemotherapy and then to go and say that antioxidants are harmful? I try to sort of have a nice relationship and not to get too anti-medical with people because they've got to go and have consultation. But I think in this instance, I did say he was a bit of a pillock. And to ask for just ask for the research, evidence-based practice, please. That's what they keep telling us. So, get with it. So, yes, the suppression of the immunity. What we want to do is to, if someone's going to survive cancer well, their immune system's got to be doing it. Once you have a treatment, the immune system's got to be up. And we need the natural killer cells, the T cells, the dendritics, the B cells. They've got to be activated, and this is from the European Journal of Immunology, showed that actually inactivated natural killer cells, when placed in a normal cellular environment, became active again. So that shows us that environment's changed. If it's changed from being inflamed, if it's changed from being hypoxic, that yes, you will allow the immune system to do what it wants to do. There's an American scientist, Nina Bissell, I think I mentioned her in a bit as well, actually. She's got a marvellous thing on the internet showing breast cancer cells in a petri dish and in an inflamed environment, etc. And these cells are all running about like crazy, completely no idea what they're doing. And she put them into a normal cellular environment, and they just all regimented, went back into normal. So, it's all there. And Yeah, and the whole thing of, glucose metabolization, cancer cells metabolize glucose up to 400 times the rate of normal cells. And interestingly, this work is by Nina Bissell, who's done a lot of good stuff. Chicken and egg, what comes first is the metabolization of glucose resulting from cancer cells becoming active in that, process taking place, or is it happening first? And interestingly, since we do more functional testing now than we've ever done, and we're learning a lot more, the number of people who've got high fasting blood sugar, even on, even in light of a very good diet and, everything else, even some, glucose modulators, still got high fasting blood sugar, it makes you think. And, Nina Bissell has sort of, projected that a dramatic increase in sugar uptake could be the cause of oncogenesis. And what's been identified for those oncologists who don't want to know about this is that there are several what's called the GLUT3, GLUT4 pathways, and there may be more. And there's, the uptake of glucose is fantastically active. In some cancers more than others. Interestingly, some of the cancers that are aggressive and that don't respond well to treatment are the ones that utilise glucose more. So things like pancreatic cancer, that is difficult to treat and doesn't respond well. And of course, that fits in with the theory that actually, because that metabolisation is so good, it's generating its protective shield. And interestingly, Cancer Research UK, who put this out last year, that mannose, which is a type of glucose, can slow tumour growth and enhance the effect of chemotherapy in mice, and they're now putting this into clinical study. It's the first time I've ever heard Cancer Research UK use the word glucose and cancer in the same sentence. And if you actually go on Cancer Research UK's website, I haven't done this for a couple of months now, but they actually have a thing called their top 10 myths, and I think number 3 is that cancer metabolises glucose is there as a myth. So they're getting a bit schizophrenic, these people, so they really ought to make their minds up. So this is what happens with glycotic metabolisation. We get a production of lactate. That generates extracellular acidification, and it changes the pH ratio between the intracellular and extracellular environment. And we get a decreased absorption of drugs. This is why drugs don't work for some people. It's still a game of chance with chemotherapy at the moment. And we haven't got too much time to go into all that, of how drugs are chosen and all the rest of it tonight. But largely still, it's a case of you have this type of cancer, this is the drug that works for most people, we'll see what happens. And what can happen can be anything from a very, very good result and a very nice story to the tumours actually growing through the chemotherapy, which I've seen this a couple of times in the last few weeks, which is disastrous. So not only have they invested their time, effort and their health, they've got nothing to show for it. And if that happens, the chance of them responding to further drugs is actually very low. And interestingly, there's some recent research came out on the environment in the body that can then affect metastases. And what's really interesting, bone metastases from hormonal cancers. It's one of the funny cancers whereby someone can be treated for hormonal breast cancer and everything's great, and then 10 years later they've suddenly got bone metastases. Olivia Newton-John's a good example of this, where everything seems fine. And why do they become active? So this is what actually happens, is a whole vicious cycle is set up in that environment where tumour cells stimulate bone reabsorption, which then stimulates further tumour cells. So basically what happens there is there's actually factors in the bone marrow that are putting out growth factors that are encouraging that to happen, and that stimulates certain things. So the evidence is coming through that actually those metastases will have been there right from early on, just waiting for the right time and environment. And obviously she's a lady who's done a great deal of personal work on her health and everything, so that might have influenced it. But it is always self-perpetuating by cancer cells. And then from primary tumours, when cancers want to metastasise around the body, they can spread via the lymphatics, and That's interesting, actually, because some new research, normally when cancer cells metastasize, they need to set up an independent blood supply and do it quite quickly. You can have cells circulate around the body, and that's not really a great problem because they can be quite immature, they may not have the ability to set up, but when they spread, they do need to do angiogenesis, and I'll go into that a little bit more. What's interesting is, of course, we've got millions, no, hundreds of lymphatic nodes around the body, all over the place, and it's now been found that actually cancer cells don't need to create their own blood supply when they go in the nodes. So they can actually be quite immature cells that aren't going to do an awful lot in the nodes. This is particularly significant with ladies who have breast cancer because, of course, the lymphatic nodes, there's loads in the armpits right next to the breast tissue. And that might just actually be localised spread rather than metastases. Where they do get problematic is if they block the lymph nodes and block the flow. And if you've ever got anyone who's got lymph node metastases, the only time you worry about them really are when they've got blocked flow or it's in the mediastinum in this area around here, because that can actually have an effect on breathing. So we need to try and get that sorted out. And so what makes cancer cells aggressive? Each cancer behaves in a unique way, and each person's cancer then behaves in a fairly unique way as well. But cancer tends to spread uniformly. Colon cancer will go to the liver first of all. Kidney cancer will go to the lungs. Hormonal breast cancer will go to the bones. They each kind of have an environment that they like and that they thrive in. And they need to adapt and master that. And angiogenesis, the formation of blood vessels, is achieved by them putting out a protein. And the blood vessels around will send lots of little blood vessels up into the tumours. And that's driven by inflammation, it's driven by hypoxia, so the more that body environment is like that, the more likely they are to get spread.
Sorry, can you just say that again? What about the protein bit?
Oh, they put out a protein called VEGF, and that just switches on the ability of the surrounding blood vessels to send vessels into them.
Okay.
And how we intervene with that, the medical profession hasn't got many drugs that do that. But it's been discovered that copper and iron are utilised by cancer cells to develop angiogenesis. And there's a lot of work been done in America whereby they use chelation. And chelation, as you know, is you put a compound into the body that metals latch onto. And if you lower copper in particular, iron obviously you don't want to make somebody anemic, you can lower copper to 20% without any problems at all. That actually stops angiogenesis. Studies done over in America, and they did them, of course, on the angiogenic tumours, so melanoma, triple-negative breast cancer. Just by lowering copper, they were putting people into remission for 6 or 7 years, which is far better than we achieve over here. And so that's the difference between a well-differentiated to a moderately differentiated and poorly differentiated cancer is its ability to mutate and to take advantage of its environment. But importantly, its environment has to be like that. And if anyone's been through chemotherapy, it actually really does leave people with that kind of environment. So, that's just summarise it really. It's all about genomic instability starting, and then angiogenesis, inflammation, and communication by that. And oxygen, aside from, we're going to come on to supplements and diet, etc., but oxygen is a big game changer. It's when I see environmental change and things change with people tremendously, is to oxygenate the body. And of course we know all the research shows that people who exercise well during treatments or when they've got cancer will survive longer. And the more oxygen we can get in, oxygen's a great anti-inflammatory. The more oxygen we can get into the person, the better. And when tumours grow, they outstrip their oxygen supply, and it causes the p53 protein to become unstable. Are you familiar with the p53 protein? Okay. The p53 is one of the most mutated proteins and genes, I should say, with cancer. It exudes the protein, it is a gene. And in normal life, the p53 protein is what we call the guardian of the genome. So it's the first line defence against cancer. And its job in the body is to identify that cells are damaged and are different and are changing. And they come along and they either destroy the cells or repair them and get it sorted out. And once you get hypoxia in the body, it induces p53 to mutate. It's thought to mutate in about 80% of people. And that's a really significant thing, because if someone's going to be well post-treatment, it's going to be well long-term, you need the p53 gene working. It can be repaired. All genes can be repaired. You know, genetic change can happen very quickly and very well. So if your p53 isn't working properly, then you're open to cancer cells mutating again. And hypoxia induces that mutation. So oxygen therapy we're very, very keen on. And as I say, solid tumours are low in oxygen compared to normal cells. And T cells are disabled from penetrating and carrying out what they need to do. So getting oxygen into people is very important. So I've said that one already. Oh, here's Cancer Research UK again. They told me for years that oxygen, talking about oxygen's nonsense and it's dangerous and all sorts of things. And they've actually now got in clinical trial a drug for lung cancer that will oxygenate the body and increase the level of... It has to be a drug, of course. Can't do something simple like, send them up a mountain. So they've got this in clinical trial, and they've actually stated on their website that cancer prefers a low oxygen environment, and altering that will improve outcomes from chemotherapy and radiotherapy. Brilliant. So what we do is try and get as much oxygen as possible. Now, one of the things we don't have, in this country, integrated medicine's a bit difficult because it's so fragmented. We've got practitioners here, there, and everywhere. This is why you lot really need to work with cancer. But what we do have is a great facility for oxygen. We've got many hyperbaric oxygen centres in this country, and they're run by the Multiple Sclerosis Society. And people with MS, there's a lot of parallels between different chronic diseases, and low oxygen being one of them. People on MS use them 2-3 times a week when they've got flare-ups in treatment, flare-ups in symptoms. And the MS Society are largely fabulous and very happy to let people with cancer use their facilities and charge something from £10 or £15 a session. So it's not only is it a really good treatment, but it's also affordable, and it has evidence for helping with radiotherapy damage, helping with neuropathy, helping with pain, bone pain. It's fantastic with. On that note, if you do have clients who can't manage hyperbaric oxygen, reasons being perhaps they're claustrophobic, or it's too far to travel, or they just, they're not mobile enough, what the doctors in charge of MS suggest is that they get an oxygen concentrator at home and do high level of oxygen. Oxygen concentrators generate the oxygen in the chambers. And this is a machine that takes in the air and extracts the oxygen and converts it. You switch them right up, you get 90% oxygen, which is fantastic, because in normal air we've only got about 18% oxygen, dropping down to 12 as you come into London. I'm going home soon. I live at the highest point in Nottingham. It's freezing, but the air's fantastic. So we get people to get those, and they use them 2-3 times a day for about 40 minutes. They can pick them up on eBay second-hand.
What is it called?
An oxygen concentrator. You do get cheap Chinese ones, but they don't get the same. You need a 5-litre one.
Sorry, are these slides available on the
Yeah. Sorry, yeah, they are. Sorry, I should have said watching people photograph, sorry.
So did it say 5 litre?
5-litre oxygen concentrator. Yeah, switch it right up. You don't want somebody doing high levels of oxygen for long periods of time, because we have an oxygen centre in the brain, and that can get confused if you have hours and hours of high oxygen, but 30-40 minutes, perfect.
And does that put it into the air in the room? Or do you
No, sorry,
mask?
beg your pardon, these are masks, yeah. Mask or nasal cannula. And if you can get them, so if you can get them doing exercise at the same time, they go on exercise bikes, something like that. There are clinics who are now actually charging for this People can do it at home. They can get an oxygen concentration of about £200, get on their exercise bike, or they can go to a clinic and pay them £50 a time. It's called oxygenated exercise. So they stick them on an oxygen machine and say pedal faster and charge them a lot of money. But that's the way it is.
So 3 times a day, did you say?
I generally go about 3 times a day, yeah. And it's very energising. You see people change tremendously. So as I said, hyperbaric, down-regulates inflammatory cytokines and up-regulates the immune support, the interleukins, which is brilliant. So it does a lot. The other thing to use alongside it, again, before we get into what you guys do, but heat and oxygen are used in combination. And in the integrated clinics around the world, and I'm very pleased that the integrated clinics around the world are getting much better than they used to be. We've had some dodgy ones and some dubious people, but things are changing. Hypothermia is used as well because hypothermia heat treatment will make cancer cells more vulnerable. And it actually affects the hypoxia state as well as the oxygen. And my ideal thing for people at home is to get them to use an infrared sauna and have an oxygen machine going at the same time. It's like a mini clinic, and that's brilliant. And that thermal stress increases the oxygen delivery to the cells and also increases natural killer cells. In most places, most integrated places around the world now, they won't give chemotherapy without using heat treatment first. They all look now to prepare the body and then do that. There's hypothermia centres setting up all over America.
And you can do all this while people are having chemo?
Yeah, absolutely. They will get better results and they will deal with it better and they'll feel better. So, chemotherapy. I'll just flick through these very quickly, just to give you an idea of the potential side effects of chemotherapy and radiotherapy. You are getting the slides, ladies, by the way. So, sorry. It's all right, I'm not putting you off, just in case you didn't know. Okay, so it's the chemotherapy, radiotherapy less, but chemotherapy can be absolutely devastating. And you get all sorts of problems, including secondary cancer, fatigue, skin disorders, kidney problems. It varies according to the person and according to the drugs. Generally, when people are told they're going to have chemotherapy, largely they get a long list of side effects. Nobody ever gets that amount of side effects. They really don't. I generally start people off looking at sort of 4 main potential, because if you looked at each side effect and thought, I've got to put a strategy in for each of those, you're going to have somebody who's on 1,000,001 supplements and 1,000,001 things, and that's no good. Because they can only do what they can do during chemo. So I tend to look at the gut, the liver, inflammation, and there's another one I've forgotten about. It'll come back to me in a minute. And start them off on that, and then see how they get on, because we need to evaluate them quite a lot during chemotherapy. So don't go too mad with them. And fasting. Fasting is amazing. Fasting has become quite popular over the last sort of couple of years or so, and there's quite a lot of research being done on it now. And when we first looked at fasting with clients, we were hoping it might help. It's actually dramatic how much it changes things, and I've been absolutely shocked because I didn't realise that it was going to have such an effect at cellular level. But also people come through without side effects. And I thought, yes, of course, if you starve the body of glucose and you lower the defences of cancer cells, you're likely to have an effect on making things work better. But I want people to have less side effects the way they do. But of course, fasting is such an anti-inflammatory, and it helps the gut. So, it's been great. So it raises the level of bone marrow cells. It raises the level of the regulatory cells, and it varies, what you do with people. Low calorie is supposed to be effective as a water-only diet, but obviously it's a very individual thing whether people can fast or not and how long for. I generally tell them to sort of have a go and start off and see how they get on, rather than go for a 3-day fast or something like that. And you know, obviously we don't want them being unwell, but it's surprising how well they adapt to it, especially when they start to come through well. And when we have chemotherapy, there's a major amount of immune depletion. All the lymphocytes, all the white cells drop down significantly. Chemotherapy is a balance between they give enough to push someone to the edge in terms of what their immune system can stand, and then allow them to bounce back. I mean, the only reason most chemotherapies are given every 3 weeks is to allow the immune system to bounce back. If you want to get rid of cancer, you just give someone cisplatin every day, non-stop. You will kill every cancer cell in the body. You'll have no person left at the end of it because they'll be dead. But you can do it. So that balance is to allow it to bounce back. And depending on how well they do that, they can carry on giving the treatment. But the impact can go on significantly for a long time afterwards. A lot of the research shows that people don't recover from chemotherapy for 6 months, 9 months before normal lymphocyte level. These are the natural killer cells that should be stopping any more cancer cells from circulating. So not to be able to get your immune system back for 6 or 9 months, because that's how long it takes without support, is absolutely ridiculous. And inflammation as well, because of this inflammation. Chemotherapy causes a terrible amount of inflammation in the body. And there is no treatment recovery programs in place in the UK following radiotherapy and chemotherapy. And tumour necrosis factor signalling is a very high contribution to both inflammation and fatigue. If there's one thing that people say is the worst symptom, it's not vomiting and it's not neuropathy, but it's fatigue. You know, that really wake up in the morning and get out of then, oh, here we go again, another day feeling absolutely crap and not having the energy to engage with life. And if that's going on for a long time, it's really bad. And then people have things like long-term sleep disturbances, depression, and these are all coming from direct biological processes. These are not happening by accident. It's being caused by the treatment, and inflammation is causing a very large part of that. So I think, the more you look into these things, you think, well, to give these treatments without supporting people and helping them recover is mad. Stick them on this conveyor belt and chuck them off the other side, and say, there you go, that's lovely. It's really bad indeed. And chemo brain is another one. Chemotherapy causes inflammation, and again, inflammatory cytokines cross the blood-brain barrier and they affect the brain. You get this a lot as well with ladies on hormone therapy. If we get a chance to look at that, the dropout rate from hormone therapy because of chemo brain, tamoxifen is about 50% within 2 years will stop taking it because of this and because of the psychological disturbances. And you can also get this caused by low blood counts and infection and anxiety and insomnia. And let's face it, most people who've been through treatment have a combination of those things. So things that we can use for chemo brain, all anti-inflammatory, all aimed at getting across the blood-brain barrier. What should be on there as well is lipoic acid. Lipoic acid is very good for helping transporting compounds across the blood-brain barrier. I say this is not exhaustive. I'm sure you can come up with other things. LDN is low-dose naltrexone, which is a repurposed drug. There's a lot of work going on that. I'm going to talk about that at the end if I get a chance, but there's a lot of work going on blocking metabolic pathways with that. And naltrexone works on the opioid receptors in the brain. It kind of wipes them clear. People say it's like the veil lifting when they have naltrexone. Really good. Used at very low dose. It's a great strategy. And another problem we get with inflammation is peripheral neuropathy. This used to occur a lot more when I was running chemo clinics. We used to have, we had drugs that started to cause neuropathy, and because it was in its early days, I don't think they realised the extent of the damage that we're doing. So neuropathy again is nerve damage, and this is what happens with the brain to a degree as well. Because of those inflammatory cytokines, they are causing inflammation to the nerves, and it's basically nerve damage. But the nerves in the hands and the feet are very fine, as they are in the brain. In the centre of the body, our nerve fibres are quite robust. As it goes out to the peripheries, they get finer and finer. And so people get very painful hands and feet. They get a lot of pain when they transfer from cold, they put the hand in the fridge to get something out and it's painful. And I've seen people who've been taken to the point where they can't walk anymore because of neuropathy. Doesn't happen so much these days. They tend to stop it before it gets really bad. But we can't prevent neuropathy completely, but we can help people to recover from it. So B vitamins, we've got a lot of evidence for this. Lipoic acid again, anti-inflammatories, omega-3s, glutamine, hyperbaric oxygen, absolutely brilliant. And any of what we call, I don't know what to call them, people call them the soft therapies, reflexology, massage, things like that. Anything like that is going to help healing. Well, soft therapy sounds a bit... diarrhea is another big problem with chemotherapy. Chemotherapy actually wrecks the gut, absolutely wrecks it. And I've got some functional testing to show you on this later. You need to be really proactive with the gut, with inflammation. If it's allowed to become terribly inflamed, it's going to cause people a lot of problems. And it's not just the fact that they have diarrhea during treatment. Recovering the gut afterwards can take a very long time. And I generally find that a lot of people sort of say, oh yeah, I've had some gut problems on chemo, I'm going to take probiotics. Probiotics aren't enough in my experience. You need to do lots of anti-inflammatory work as well. And also look at, hopefully, do a gut test. Has the person got candida? Have they got H. pylori? That comes up a lot after chemotherapy. Sometimes, aloe vera enemas are very useful for people to get right into the colon. And lots of different good probiotic mixes. The healthy company's got Micromax, which I haven't got on here yet. Apologies for that, but that's one of the best mixes of multiple probiotic preparations that there is. And they need to work on this very long and very hard. Sorry.
Chlorophyll enemas work.
Yeah, chlorophyll enemas. Oh, I hadn't thought of that, thank you.
Chlorophyll enemas.
Right.
So very healing.
Yeah, anything basically, yeah, absolutely. Anything that's likely to get in there and get, some people use coffee enemas during chemotherapy because they cause a liver flush. And that can be okay. People generally do feel better when they do them. But I do get concerned if they're used quite intensively because that's quite ascorbic to the gut wall. And the lining of the gut is very, very delicate, The cells in the gut are the fastest reproducing in the body. They literally wear out, so they get most affected by the chemotherapy. And I think depending on the situation, if someone's got an inflamed gut, coffee enemas are probably not a good idea. If they don't, then fine. 6 a day's DOF though, just in case anybody wonders. That's the Gerson therapy thing. When you have a coffee enema, it causes the gallbladder to contract and flush the liver. The gallbladder is not a petrol pump. It doesn't fill up 6 times a day. So you've got to think that's not a very good plan. So immune support on chemotherapy, again, vitally important. BioBran, our sponsor got out there, is definitely one of the best. It's a bit pricey, but it's generally worth it if people can afford it. And sometimes if they're a bit pushed, what I tend to do is sort of say to them, give it a go for 2 months and let's see what a difference it makes to your, to your blood counts. And even as a boost for a couple of months, you generally get very good benefit. I generally do like, and people can get them and they should have them, is whenever clients are having chemotherapy, get them to get their blood results each time. And you can start to see, because there's a lot of things that happen to the body that is fine by doctors. We can see the things that we're looking for, we can see the underlying elements that we want to address. Where doctors go, yeah, your bloods are fine. And then you look and think, no, they're not. You can see things that are going on there. And this is not exhaustive, there's lots and lots of different immune support that we can give. Liver support becomes massively important. These are the chemotherapies that cause the most problem to the liver. And serious damage, very serious damage is occurred. The whole thing with the liver and cancer, the liver and the gut are the two, like any other ill health, isn't it? The liver and the gut are the two most important areas. But we do come across quite a lot of issues with cancer where liver detoxing pathways are not functioning properly. And, a real clue to this is somebody reacts to drugs. If someone says, oh, I'm really sensitive to drugs, usually either the glutathione or one of the other pathways is not working properly because, and you can test for these. Genova do a very good detoxonomic test which shows us which ones aren't working. But generally, if you give two people, similar people, there's a drug at the same dosage, the idea with any drug in clinical study is it's supposed to break down to its half-life. That's when it's half as strong as it used to be. And that will cause so many side effects, and that is what studies have worked on. That's acceptable, okay, the patient hasn't died, it's acceptable, they're okay, they've bounced back, that's fine. But then if you get someone who's flattened as a pancake or is really ill or anything like that, what that means is that half-life hasn't happened. That drug is still circulating, and they need a lot of support with the liver, or they need to have less chemotherapy. But getting doctors to give less chemotherapy because the patient isn't coping well, it's kind of, our criteria is it's got to be this dosage. I said, well, clearly the liver isn't coping well. There's actually a drug very commonly used called 5-FU, 5-fluorouracil. And there is actually a liver enzyme defect in 20% of the population that they cannot metabolize it at all. And if they have it, it will not leave the body. It will just keep circulating and damaging the liver. And they die. And they don't test people before they're given 5-FU to see if they've got this liver enzyme. It's a bit of a big gamble, I think.
Is that chemo 5-FU?
Yeah, 5-fluorouracil.
Is it for specific cancers or?
It's used for breast cancer, it's used for it tends to be a bit of a mixer. They put it in with lots of them. Bowel cancer and breast cancer they definitely use it for. And they tend to throw it in with other things as well. There's a lot of chemotherapies, there's about 50 odd chemotherapies and new treatments.
So what is the enzyme that they're lacking?
I can't remember specifically, but if you email me I'll tell you, I'll look it up.
The DPD.
DPD, thank you very much. See, my clients usually know more than I do. Often the case. I sometimes get clients, I talk about clients being informed, I sometimes get clients sit down in front of me and I look at what they've done and go, I hope I've got something to offer here because, it can get embarrassing. They know so much. So, liver support strategies, again, there's loads more. I'm sure I've got more slides on this. But the more support, the better. Another thing with infrared saunas, it uses the skin as a detox organ. It's a useful detox organ, the skin. So that helps tremendously. Liver packs as well during acetylcystein's very good. Castor oil packs when someone has an infrared sauna. It's very, very helpful for drawing toxins out of the liver.
What is the best home infrared sauna?
Well, they come in all sorts of shapes and sizes. Good question. The thing with infrared saunas is most of the technology is actually in the panels. So what they house them in is what they're paying for.
Okay.
So if they want a big Swedish type sauna and run around in the cold afterwards, that's fine. The small personal ones, the difference we've worked out so far is that the tunnels like sleeping bag type are not terribly strong. And then you get up to the kind of the half tunnel ones that people, or the ones that they sit in, and they're much better. I generally recommend a company called Furzone. For the simple reason is they sell the same stuff as everybody else, but quite a bit cheaper. F-I-R-Z-O-N-E. Furzone. Yep, they've always been...
Sorry, so this support would be done while they're on their chemotherapy, or is it once they're live with the chemo?
You can do it either way because a lot of the time this thing has come up about not actually doing something while they're actually having the chemotherapy. That's mainly done to pacify doctors that we're going to back off for 3 days. it doesn't actually make a lot of sense, because if you're taking something, there's still going to be some of that in the body anyway. And the patient, client, shouldn't be having anything that's going to interfere with the chemotherapy. In fact, it's going to enhance it. Sometimes it's just done politically, so say they won't back off for 3 days. But you can look up the drug's half-life, because it varies tremendously. Some drugs will only have a half-life of about 4 hours. Some will be 6 hours. It really can be as short as that. The majority are between sort of 12 to 24 hours. But now we've moved into the realm of immunotherapies, and the half-life of immunotherapies can be like 3 weeks, or even months. So, you know, and some oral chemotherapies and some drugs now are given every day. So they give smaller amounts every day. So you don't get that. So, you know, I don't really pay a lot of attention to that, to be quite honest. And interesting that chemotherapy prevents the utilisation of vitamin D. It prevents the utilisation of most things, but vitamin D is massively significant because obviously it's a steroid, and its job is to reduce inflammation in the body. Vitamin D is implicated with so many types of cancer in terms of the instigation of the cancer and then the potential for preventing recurrence. And in this country, our doctors have clicked onto vitamin D, which is great, but the recommended doses here, and actually what's happening now is we're seeing so much variance between doctors. It used to be a bit uniform. Now they're all coming up with different figures. And, you know, somebody might get a measurement back that's about sort of 60%, 70%, and the doctor will say, yeah, that's great, that's spot on. It's not, it's nowhere near. Internationally, vitamin D levels are viewed as being 125 is kind of your minimum. Anything between 125 175. And this research showed that, and often I come across people who've got really low vitamin D levels. That was part of the whole process of cancer starting, and they might have a vitamin. I come across somebody last week got vitamin D level of 40. That they've had it, you know, it's been like that for years. And this research is from Roswell Park is showing that actually, because of the effects of chemotherapy, we need to supplement vitamin D even more than we thought we did. You know, a lot of us were running with 5,000 IUs a day, and clearly it's got to be, you know, at least 10,000 a day, and are actually just not going to get the vitamin D back up, and they should have it checked while they're on treatment.
Is that for someone who's having chemo?
Yeah. Yeah, and it's one of the things that they really need to be monitored as well, and particularly, you know, after chemotherapy as well, to bring the dose back down again. I mean, we don't know what the therapeutic ceiling is on this. I do know some practitioners who use 20,000 or 30,000 a day. I haven't gone that far. I don't quite see the need for that, but I think you know, we need to keep an eye on that quite closely. So the immune system damage we get from chemotherapy, obviously, so it reduces key immune cells. Recovery can take a long time, and it affects antibodies. And lack of immune support during treatment can cause a massive problem with cancer bouncing back. Some people don't have much time off from chemotherapy before cancer's back, and it's a very common thing now, unfortunately. You know, there's some things that are curable with chemotherapy, as they always have been: leukemias, lymphomas, testicular cancer, tonsils. Don't know why tonsils, but they do. And head and neck cancers can respond pretty well, although they're responding well to immunotherapy now. But a lot of the time, if it's beyond an early stage cancer, and you know, there are questions to be asked about: should we give chemotherapy to people with early stage if they've had surgery and it's done as a mop-up? They've actually now moved away from giving early breast cancer chemotherapy as what they call the belt and braces. They've realised it's not doing any good. And I think we'll see that happen a lot more. But for a lot of people, they have who've got, you know, stage 3, stage 4 cancer, they'll just end up in a cycle of chemotherapy with a bit of a break, and then more chemotherapy. And you know, this is something I used to see when I was back in my day. Nowadays they're very honest with people, almost to the point of, you do know you're not going to survive, don't you? You do know it will come back. You know, they kind of gone very far that way. Back in my day, we didn't lie to people. We didn't say an awful lot. We kind of, I think there's a lot of faith put in doctors. Questions weren't asked. They were just like, yep, okay, I'm being treated, it's all good. But, we'd have in our head, I'd have in my head, oh, it's an ovarian cancer, we're going to give this chemotherapy, she'll be back in 6 months. And, you could almost map it out. And then you get to the point where you say, okay, we haven't got any treatments left, it's resistant, we're done here. And I can distinctly remember, the amount of sort of shock and anger from people. How did I actually get here? Because here is not where I thought I was going. Oh God, well, we did. So now things are much more actively honest. But, as I said to my clients, they only reflect, and a prognosis only ever reflects how little they can achieve. They're sort of saying, okay, this is going to come back. This might work for a while. It might hold it a bit, but then, it's all going to become resistant. That reflects that, what can achieve by doctors. Nowhere in that equation is what the person can do for themselves. And if we can get that across to our clients, that they're actually far more important than doctors, and they can achieve far more than doctors can, then, then they can really empower themselves and run with things. And I think it's vitally important that they're given a perspective, because I've got a lady who lives near me, Julie, and I met Julie 15 years ago. I know I was pregnant at the time, so I can always remember that. And she had HER2 breast cancer with spinal and brain metastases. And at that time, our first conversation, I remember, was, is this going to be my last Christmas with my 2 sons? She's got two adorable little boys. And she is fine, 15 years on. Her boys are at university. She's moaning like mad about the university fees. One of them doesn't talk to her anymore. It's all changed. But, she's gone from that. Her oncologist has claimed all the credit, of course. Julie's had nothing to do with it. But, she worked and kept at it. And her orthodox treatment helped. Of course it did. But it was working with it that's made the difference. And, she's had a really, really good time. So that's great. So just going to have a quick look at immunotherapy, because that's big news these days. And also to bring in where BioBran can help support that, because BioBran is one of my favourites, and it does actually. There's not many areas of support where it's not effective. It's slightly unique compared to some of the other things, and
What is it?
it's a rice bran, Japanese rice bran. Combination with shiitake mushroom. I've got a bit of info for it on that, and they got plenty outside. So immunotherapy. So we're moving now into. Can I ask, what is your you've heard about immunotherapies and you hear about it in the news and all that. What's your impression of immunotherapy? How good it is? Has anyone got an idea?
It's
I'm concerned
individualised.
about it.
I heard it's very promising.
I have concerns about it.
It's very interesting, I have to say, because there are certain areas where it's working incredibly well. And there's always been the perception that if we have immunotherapy, it's working with the immune systems. That's great. It's not chemo. Whew, great. We're out of trouble. Oh, we're not. It's remarkable. It's absolutely game changing with melanoma. I was out at the weekend with some friends in Yorkshire, and one of our friends, Graham, has melanoma, stage 4. He's been in remission now for about 2 years. He's doing well. Lots of support. With melanoma, that is a game changer. Go back 5 years, melanoma, you'll be out of here in no time. And it's doing great with kidney cancer, and they've now just done some studies giving it to people with head and neck cancer as a first-line treatment. And that's the difference. If they give it as a first-line treatment, it seems to be working better. But it has a lot of side effects, and in some cases, I'm lumping all immunotherapies together here, because obviously there's lots of different ones, and there's T-cell inhibitors and things. But in some cases, it's causing worse side effects than chemotherapy. It's devastating. And if you look at the statistics across the board, the response rate to immunotherapy is just 20%. So it's 80% of immunotherapies are given for no good effect whatsoever. But this is a great area that we can work with because it's our area, it's the immune system. And actually this is interesting because it's driving a lot of the research into integrative medicine. Because in America, the insurance companies have looked at the results and said, really? Yeah, sorry, that costs £80,000 and what? The cancer's back after 4 months. And they've told the drug companies, come on, find better ways to get these things working.
Is it as toxic as chemotherapy? Is it carcinogenic?
It's not carcinogenic, it is absolutely wrecking the body. So it's different. And it's very disappointing, to be quite honest, because I was optimistic as everyone else. It's a different area of side effects altogether. The main thing being the gut. Oh, it wrecks the gut to pieces. It really, really does. So, but that's an opportunity for us. But the big issue with it is T-cell exhaustion. And basically our T-cells, which are so important when they're treated with immunotherapies, what's happened is you're trying to get a response from the antigen. And what happens when you give it is it doesn't respond, because a lot of people don't respond at all, because the T-cells have become inactivated by the process of cancer, or they've had chemotherapy and their immune system's utterly depleted. And there's also a level of epigenetic programming in here where the methylation factors aren't working properly, the DNA methylation factors, they'll get T-cell exhaustion. And so what do we do over here, and to be fair in most countries of the world, is we give people chemotherapy, and then we give them more chemotherapy, and then, just a bit more for good luck. And then when that fails and the cancer comes back and the immune system is shattered, we'll then say, oh, let's give you some immunotherapy and expect it to work. And of course it doesn't. And the more active T cells are, the more we can support them, the more significant decrease in tumour growth you get. And interestingly, cholesterol is playing a part in this, because the things that immunotherapy is doing is it's raising cholesterol levels, particularly LDL. And LDL, when high or imbalanced with HDL, will suppress the T cells. This is why statins work well against cancer, which is kind of annoying. We don't like statins, but I can't deny the evidence they do work well against cancer. Damn. But there's other better ways of dealing with cholesterol. But you can see a significant... I did some testing on a guy with Hodgkin's lymphoma recently. He's always had a very good lifestyle and looked after himself. And he was actually pretty angry at the results. I don't think he believed that they were as bad as they were, but they were because of that process that's taking place. So cholesterol binds and stabilises receptors. And so Biobran is one of the best immunomodulators. Turmeric's a good immunomodulator, beta-glucans are a good modulator, but just looking at Biobran, this is a rice bran extract that's been hydrolyzed by the enzyme carbohydrates from shiitake. Very clever stuff. And out of all the, you'll see from all the literature out there, it's probably got more research than any other compound, which is helpful because, doctors are all the time saying to us, yeah, there's all these supplements, but they never do any research. And a lot of companies who produce supplements don't do any research, don't do any studies at all. So it's really good to see a company that does do proper research. And so MGN enhances the cytotoxic reactivity of immune cells and increases the production of interferons. So it's used as a natural adjuvant for dendritic cells. Dendritic cells are very important. And actually, there's a treatment called dendritic cell vaccine. Sorry, I jump all over the place, I'm sorry. But dendritic cell vaccine, which is a treatment given to reinvigorate the immune system. And that's it's been around for a long, long time. It was around, 20 years ago. And they never got it to work because they couldn't get the dendritic cells to work But now, because of things like BioBran and other things, because immunomodulation has really come along sort of scientifically, now dendritic vaccines are actually working pretty well. People go to Germany for them, sometimes Mexico. Quite a few European countries do them now. And I've just had somebody treated in Germany for a brain tumour, who'd, I think, had got to the point where her chemotherapy wasn't working anymore. And she's improved fantastically with dendritics and MGN. So the thing with one of the good things from my point of view, I'm always looking at resistance to treatment. Same with supplements as well, because you can get hyper-responsiveness where the cells just don't respond to the compound anymore. It doesn't matter how good a chemotherapy is if it becomes resistant. It doesn't matter how good any natural compound is if it becomes resistant. I was having this conversation with somebody yesterday. I was saying, we will sort of mix things up and start to swap things around after 3 months. He's going, well, what if it's working? I says, we still change. Didn't like that at all, actually. I said, no, there's a great comfort in people look for the winning combination. And yes, I've got there. But actually what, you need to do as well is always have an eye on resistance and change things around and move things. And the good thing about BioBran, it doesn't exhibit hyper-responsiveness at all. So we'll keep going. And, their studies have shown they can even maintain increasing natural killer cell activity over a 5-year period, which is awesome. Interestingly, I talked about the gut, and we're going to come on to that a bit more. The gut is important for the activation of drugs. Some chemotherapies need a healthy healthy gut to activate. And they've studied have shown that people eating high fibre diets are about 5 times more likely to respond to immunotherapy because the gut is healthy, and you need the enzymes from the gut in order to do that. So it's because the gut is modulating the immune system alongside everything else, the actual immunotherapy works better. So a high fibre diet is one of the most significant effects on new immunotherapies, which I just think is absolutely brilliant. Yep, done that one. So things that BioBran does, help people maintain weight. I'm hoping we'll get to the weight loss bit, I don't know. Natural killer cells, reduces inflammation, increases neutrophils, particularly when combined with curcumin. And even if you only use it for a short period of time, people will always get great benefit. If I've got people whose immune systems are flat as a pancake and anemic and not bouncing back up, this is kind of where I go to get them going. And these are the things that I've observed with BioBran. Increase in all blood counts, recovering from sepsis, reduction in cachexia, fatigue, and reduction in gastrointestinal problems, so it works well on everything. A quick case study, but I'll zip through this because we've got lots more to talk about. It was good. Okay, you can look at that yourself, sorry. If it wasn't, it's not going to be up there, is it? Let's face it. So. That's just a summary, really, on we need to do an awful lot more to help people, which we do. And so how do we know what's gone wrong with people and, all these different deficiencies? Well, testing, functional testing is providing us with a great deal of information now. And this, I use the thing, gentlemen, functional FDX, is that a test anybody else uses? Functional FDX is a test, because obviously there's so many tests, isn't there? And you kind of think, well, people have only got so much money to spend, etc. But the functional FDX test I've been doing for about I come across it about 18 months ago, and it's a very large report. It's one blood test, about 7 vials of blood, that shows us every imbalance in the body after treatment. And as you can see from here, this is just showing the degree of deficiency, but these are the things we see typically: magnesium, B12. A lot of this is related to gut absorption, stomach absorption. People not, for example, most people who've got low vitamin D are already taking vitamin D, but they still come out of treatment with low vitamin D. That is for 2 reasons. One, as I said, the need for vitamin D is much, much higher than was thought. And also, people often have low DHEA levels, DHEA being secreted by the adrenal glands. I think, and I might be wrong here, but I think the relationship is that people who undergo the stressful period of treatment with chemotherapy, their adrenals become flat, as we know, and they need adrenal support. And when the adrenals are flat, the DHEA levels become low as well, and that doesn't activate the vitamin D absorption as well. Glutathione with the liver is often quite depleted. That can depend on the pathway, though. And these are different for everybody, but it just shows you the degree to which they can be. So in this person who just finished chemotherapy, this was a young man who had had quite intensive chemotherapy. And you can see there, he's come out the other end of it. His C-reactive protein is an inflammatory marker, as is CRP and ESRL. These are all inflammatory markers in the body, and he's off the scale with inflammation. He absolutely is. So, he's even despite good work during it, he's still come out. So lots and lots of intensive anti-inflammatory work needed doing there to get him sorted out. And this is his liver. And as you can see, down the bottom right there, his LDH is right off the scale as well. Bilirubin's very low. He's not producing bilirubin. Again, very common. Bile is a natural cleanser and oxidant effect not oxidant, stupid. Anyway, it's a natural support for the gut, and often people can be very low in bilirubin, which is very, very unhelpful to the gut and to the liver. So not much bilirubin there. And alkaline phosphatase, very high indeed. So lots of liver strain, lots of stuff going off there. And these are the most common functional imbalances that we see in testing. Oxidative stress, vitamin deficiency, adrenals, high glucose. So you've got people who are sort of saying, I'm not eating any sugar, I'm being really careful, I'm not doing anything. Yeah, your fasting glucose is 6.8 or something like that. And that is because, I don't think we really know why that is, to be honest. It's clearly because of the cancer cell metabolization, but that doesn't really answer it, but the fact is it is. So what we do is put in lots of glucose modulators, so things like berberine, D-mannose. Some people use metformin. A lot of people. Metformin has a lot of evidence now as an anti-cancer effect in terms of lowering glucose, and also its effect on the immune system and different things as well. Inflammatory levels high. H. pylori comes up quite a lot actually, and also different gastric infections. Metabolic acidosis. You should always hopefully get your clients checking the blood sugar regularly and checking the pH regularly and finding out how that is affected. Fatty liver. Most people come out of chemo with a fatty liver, and again that has an effect on cholesterol levels and adrenal insufficiency. So post-treatment strategies, we need to sort out the gut. Numerous things that can do this. I'd make an assumption that most people who've had chemotherapy have got a degree of candida, if not a lot of candida. And that's always a good place to start, because I think if you don't do a candida clearance, probiotics aren't going to work. So either use a compound that tackles candida as well. Going in with probiotics on its own is not sufficient after chemotherapy. And so caprylic acid, biotin from a non-yeast source prevents the conversion of candida to a fungal form. There is something I shared with me the other day. There's a lot of issues with breast cancer, hormonal breast cancers and fungus and candida and things like that. So there is a reason to be a little careful with fungi in supplements, just with those. But Micromax, again by Really Healthy, has got an awful lot of different microorganisms and herbs in them, and is also, although it's a fermented product, it can be used as part of an anti-candida program, and is a very good digestive cleanser as well. So that's kind of quite a good all-in-one all in one process. And generally I tend to find that unless you do the gut, unless you get that sorted out, they're not going to absorb the supplements. So do it first. A lot of people don't like that. I find a lot of people, I sort of say, what I want to do is spend a few weeks just working on your gut, and then we'll go back onto the programme. And they're like, no, not stopping the programme.
I use money when I'm talking about.
Sorry?
I use money.
The universal language.
Marvellous.
Exactly, they're just going through. And that's a good thing with testing, isn't it? Because you can actually show them what... and it also... It also directs us to where we need to be. I appreciate for some folks money's an issue, or money's an issue for all of us, isn't it? But the FDX test, I think to practitioners is about £300. It runs to about 70 pages. Some of that's repeated. You know what labs are like? They like to show off, so they do it in lots of different ways. But there's a lot of information there compared to some. I mean, my three favourite things, I think, as a generalisation, is the FDX test, a good gut test, and a liver detoxigenomic test to find out what the liver pathways are doing. And I think if you do those three, you'll cover most things for people, for sure. And so in the gut again, grapeseed extract, very good on the gut. During chemotherapy, significantly decreases intestinal damage compared to the controls, by about up to 55%, which is really good, really useful. We've got a few definite contraindications. I'll leave you to read these at your leisure when we send it through. Warfarin is the main thing. Warfarin is an absolute sod. We hate warfarin. It interferes terribly. One of the things is that a lot of things alter the way that warfarin is metabolised in the gut. I would say warfarin doesn't get used so much now, it only gets used for the really serious anticoagulation. A lot of people get put on anticoagulants for different things. All come with the same warnings, do not take any supplements that may interfere with that. I do a lot of work with anticoagulants, and as long as you're building things up and doing it carefully, I've never had an issue, literally not. I always tell people to look out for things like bruising easily, bleeding gums when they clean the teeth. But I've actually found that you can build up programs without any great problem, as long as they're on one of the low-level anticoagulants.
So that's the first one is so Velocade is a chemo.
Velocade is a chemo, yes, used for myeloma, and green tea gets right in the way of it. And there's some evidence that fish oils gets in the way of the platinum-based chemo.
So statins and berberine are quite common with the off-label meds. So the Jane McCullen, she puts those together, doesn't she?
Yep, she does. But in I say no one's there definitively yet.
No,
But there's a lot of ideas.
Caution.
There was some very good research out, a good study a few years ago, showing that fish oils might interfere with platinum-based chemotherapy. Is actually carboplatin, cisplatin, and a lot of people were resistant to hearing it. I was working with a nutritionist at the time. We were sort of doubling up on a client, and I said one thing, she said the other. They weren't impressed by that, but it was a brand new study, and they went with the fish oils, and actually his chemo didn't work. So and it changes all the time. We can only use what's in front of us at the time. Sorry, you were.
So just want to check I'm reading that right. So the quercetin and the IP6 are shown to have
Interactions, with artemisinin. Yeah.
That's interesting. And quickly, because I do want to ask you before sorry, just flying about the FDX test. Who does that?
The FDX test it's done by Jonathan. I'm getting old, my memory's terrible. Would you drop me an email and I'll send you the link? There you go. What's it called?
I Can Help, Jonathan Cohen.
I Can Help.
I Can Help.
I Can Help. That's a real help. That's a stupid name.
I Can Help.
Drop me an email and I will direct you to his labs. They're very good.
Isn't it Dickon Weatherby's implementation, testing implemented in the UK has been put with the franchise from just Dickon Weatherby from the US?
I've no idea. No idea, sorry. Right, quick look at radiotherapy. Radiotherapy is entirely different. Chemotherapy will affect every cell in the body. Radiotherapy only affects the area where it hits. And it can be, pretty bad. If that area involves absorption, involves eating, anywhere down the gastrointestinal tract, you're going to have nutritional problems. Other than that, it's not likely to cause nutritional problems. It might cause other problems, but not those. Particularly bad for people who have treatment of the head and neck. Radiotherapy for that, it is really bad because the amount of inflammation generated is significant, and generally people get really significant weight loss. I don't know if everybody remember when Michael Douglas was diagnosed with cancer, you saw the photographs of him, absolutely skeletal. That is pretty much what happens to them. So they need an awful lot of help and support. It's all, again, down to inflammation, and that is delightfully, unfortunately, bolted to the table there. And this is what they do with radiotherapy. So a lot of research goes into people recovering from cancer getting post-traumatic stress disorder. And I think if you have your head bolted down to the table like that, it's not surprising. And, people will go through treatment after treatment. It's very insidious, radiotherapy. When you first have it, it feels like nothing at all, and then it builds and builds. And the issues can be, it's all down to heat and inflammation. The thing is, with radiotherapy, you want the radiotherapy to affect the DNA, which it will do, and that's fine. So it actually stops cells from reproducing the next time. The big issue with it, if it's in the head and neck, it's very likely it might damage the salivary glands. So you either can end up with people who've got don't produce any saliva. I know Jeff Boycott, we've done a couple of talks together, and he has no salivary glands now. He's constantly sipping up water, so they're very dry, very prone to infection. Or they can actually overproduce saliva, and I've had people who kind of just sat there mopping their mouths all the time because it's just masses and masses coming out, so that can be quite bad. During the actual treatment for a long time afterwards, inflammation around the esophagus might actually stop them absorbing or stop them eating in the first place. It can become so sore that they just can't eat at all. Bit slow in this country as well, it coming in with other methods of feeding people. They're getting better, but and the thing is, with radiotherapy anywhere in the body, the big issue with it is really it generates heat, and that heat generates inflammation. That inflammation generates tissue fibrosis, and that's what causes the problem. So if your body tissue is very good at absorbing heat, if you burn your fingers and you stick them under the tap, and you think, and you pull them out and go, yeah, they're fine, good, and 10 seconds later, it's back again. That's how quickly that heat's been absorbed by the body. And then if you left it, it will go on and on building. And this is what happens with radiotherapy. As they have each treatment, you get more heat, you get more inflammation, you get more fibrosis. And what you can't see under the skin is what's happening to that tissue. That tissue is becoming very fibrosed. I've been in operating theatres where they've opened people up who've had radiotherapy, and the damage is like, oh God, you can't see it from the outside. So there's a lot there for us to deal with. And that's an example of radiation burns. You don't see that quite so much these days. We still do get people burnt. Back in my younger days, that was quite normal. And quite nasty indeed, very painful. And fairly standard, but we don't get that now. And the simplest and best thing in the world for reducing inflammation with radiotherapy on skin is put cold packs on. And I've had a couple of radiologists ring up and ask us what we recommended, because they thought it was rather good. And simply that, because skin and tissue absorbs heat and stores it, you put cold packs on, you just draw it out, and you actually stop a lot of the damage. It's the cheapest and simplest thing in the world, and we find it works fantastically. So we get people, once they've had radiotherapy during the day, about once an hour afterwards, 10-15 minutes, cold pack, off again, let it return to normal, cold pack, off again. Even one of the most devastating things to have is internal and external radiotherapy for cervical cancer. That is brutal. And so, we get people, if they can, use douches, even sit in a cold bath, anything like that. Anything to reduce the heat, reduce the inflammation. It won't interfere with radiotherapy, it can't, but it will actually stop the burning quite a lot. Aloe vera gel's fantastic. Acupuncture is also pretty good for stopping inflammation. And you just think where it is in the body. If it's the prostate, it's going to hit the bowel, so then you get bowel inflammation. And if it's anywhere here, you're going to get dysphagia, esophagitis, etc. So just think inflammation. What can we do about that? Which area of the body needs to be fixed? And you can get a late manifestation of problems. Can come many years afterwards. One of the best treatments for radiotherapy damage and clinically proven, there was actually a study from many European countries out on this the other week, hyperbaric oxygen. Get people in hyperbaric oxygen and they will recover from radiotherapy very quickly indeed. They even found that on pelvic radiotherapy, they gave hyperbaric oxygen to women who were suffering side effects 3 years after they had the treatment, and they still improved. So doing it straight after is brilliant. I don't normally recommend they do it during. They can do, but that's purely from a point of view of having to go to radiotherapy every day, try and fit oxygen in. Radiotherapy can be exhausting. The oxidative damage is very significant and they get very tired. So if they do it afterwards, that's fine. It's not a problem. This is an area where we can use fish oils and things like lipid replacement therapy for fatigue, etc. I'll leave you to read those. And then post-radiotherapy. So, there are issues with, certain, they may get a secondary cancer due to it. I've got a client at the moment who has, and different bits and pieces. But generally, radiotherapy damage doesn't show itself for about 20 years. But of course, we're treating people younger and younger with cancer these days, so, it is an element. And PTSD and depression is pretty significant with people coming through cancer. A lot of people find that the time they finish treatment and sort of go back to, quotation marks, normal, is one of the most difficult times, because everyone goes, oh, it's all over, brilliant, right, get on with life, and the person's going, whoa, what happened to mine, There's not many incidences. Well, I think people don't suffer a tremendous amount of stress. Just having the rug pulled from under your feet in terms of your mortality and longevity in itself is massively significant. And 37% people report that PTSD gets worse after a 5-year period. So depending on what their experience was like, what the treatment was like, and also what the medical staff were like, can add to that. Empowering people is one of the greatest things you can do with cancer. It really is. Just making them feel, I'd imagine, I've not had cancer, but the loss of control, loss of sense of control and equilibrium must be enormous. So to empower people, even if everything we said was complete rubbish, which it isn't, just want to say that it's not, even if it was, the placebo effect itself would be tremendous. Loads of anti-inflammatory compounds, all these, tons of them. All good, lots of stuff to choose from. So we've got time for, we've got time, haven't we? A quick look at the difference between hormonal breast cancer and triple negative breast cancer. I did want to move on to cachexia, but we'll see how we do. So this is just for a comparison of how cancers vary. They do vary tremendously. And we deal with them differently. So estrogen breast cancer is the most common type of breast cancer. Treatment's largely successful. It's the one that gets quoted most in the papers. Survival rates are quite high. I say it goes to the bone. And it can be linked with estrogen receptors as well as progesterone receptors. Always important, because there's this thing that's been going around for many, many years now. If you have an estrogen breast cancer, take progesterone and it will balance it out. And your estrogen will go down and all will be well. That's about as simplistic as an approach to cancer as you can get. And when you're looking at receptors with cancer, they may have estrogen receptor cancer, they may also have progesterone receptor cancer, so the progesterone receptors may be active. If they are, you really don't want to give them progesterone. You really don't. And the other one's HER2, which should not be active, and is in some cases. And as I say, bones are commonplace, and compliance with hormone treatments varies. I probably have more conversations about I can't bear to be on hormone therapy than just about anything else. And of course, if it's a thing, isn't it? I always think, being diagnosed with cancer when you're well is so surreal. But you can get someone who goes and has a mammogram and they're told, okay, you've got a lump. Okay, what we're going to do is we're going to take that out. We'll look at it. We might give you some chemotherapy. That'll go on for 9 months. And then we're going to put you on tamoxifen for 10 years. And then they come out the other side of that and they're on the tamoxifen and they find that they kind of feel absolutely rubbish. They can't think straight. They haven't got any energy. The most common phrase used is, I feel like I've aged overnight. I feel like I'm 90 years of age. If that's going to go on for 6 months, most people will go, okay, I can do this. When you're talking about 10 years, and I think they will be doing tamoxifen for life soon. It's a new campaign, tamoxifen for life. Terrible jokes. I'm sure they will, because they don't fix anything. None of these treatments fix anything. They don't help the person stay well. So tamoxifen it's a blockade. It sits in the estrogen receptor. So why wouldn't they take it away? Because when they do take away that blockade, nothing else has happened as far as this is concerned. Tremendous opportunities to work with estrogen breast cancer and sort them out. It's brilliant. So it's all to do with hormonal methylation. And estrogen is pro-inflammatory. So you get this cycle continuing. But it does occur quite a lot with people who are kind of very well as well. It's not just estrogen levels. That's what I mean. It's far too simplistic. It's estrogen levels, it's the liver, it's the gut, and it's our exposure to synthetic estrogens, which we know is very, very widespread now. The amount of estradiol, there's 3 different types of estrogen. Estradiol is the most toxic, it's carcinogenic. There's very high levels in tap water. Drinking tap water is it's not tap water, is it? Yeah, I know, you can't you? That's just terrible. Yeah, tap water, I haven't got time to go into it, but it's just poison. They wanted to find out a few years ago in London how many people were taking their antidepressants. Not how many got the prescriptions and put them in the cupboard, but how many people actually took them. So they just measured how much was in the drinking water. It's absolutely shocking. So, I'm not taking any drugs. You're drinking tap water, yes you are. You're taking quite a lot. So, environmental estrogens, so loads from all sorts. Now this is the thing, when someone's diagnosed with cancer and they get in touch with the likes of us, and we sort of say, okay, what I want you to do is I want you to change your diet, I want you to start taking these things, get rid of all your sort of toxic stuff in the house, start exercising, meditate daily, and above all, don't get stressed. We have to work out what are the priorities at any one time. Don't overdo it.
How many of the water filters actually get hormones out of the water if you use
Only a couple of them. Yeah, reverse osmosis does, but leaves you with a bit of dead water. And there's been a bit of some new ones come along. You're asking.
Distilling therapies are very good.
It's very good, yeah. Distilling, I don't think gets rid of hormones. No. The trouble is with the water plants is the filters are just not small enough. So I think it's a disgrace. If you want to get people, a country of healthy people, treat the tap water.
If you
But
use a filter, is okay, is it?
yeah, as long as it's one that takes hormones out, for sure. But we can't expect clients to live in a bubble. So we're all the time trying to find a balance between doing the certain things, spending the money, not being so stressed out by it. I'm very anti-stress, and finding that balance of being able to get on with their lives and enjoy it as well. It's very easy for people in this area to get a bit sort of, obsessed about it. And one of the things with that is I always ask them, how are you making your decisions? What are they based on? Are they based on things that you know about yourself, things that you know about your type of cancer, or are they based on you're too scared about missing something, that you're pulling everything in, as everybody rings you up and tells you this is good and this is good? And a lot of the time it's that. So if we've got good reasons to, good explanations for people and good research, we can help them sort of say, okay, and I sort of say, right now, stop looking. Stop. Look inwards now, focus inwards, start to relax, start to meditate. Stop looking out there. Some are good at it, some are not. Some will still carry on.
What's your opinion on the role of phytoestrogens with hormonal cancers? Because the studies are like always 50.
It's gone all over the place, hasn't it? It's bang, bang, bang. I think phytoestrogens are a weaker estrogenic that does block. And I think the evidence does balance that out. It's a bit like the soy argument, isn't it? You know, soy, when... This is a typical thing, isn't it? Soy got a bit of a link with cancer, and next thing the whole soy industry is taken over. It's like CBD at the moment. CBD. I mean, it'll get us through Brexit. It will do everything. It's fantastic. But there's a lot of questions about it. There's a lot of things we don't know yet. No, even CBD can't get us through Brexit, can it? No. What am I talking about? Yeah, and I think, soy was a similar thing. Something like, everyone, should be awash with soy. I knew Jane Plant, actually. And, it was an assumption. And then we find out that, of course, soy is, GM grown, chemically stripped. And, if really fermented soy you should be having. So, I don't like things that are kind of, come along and everyone's popular with it. Hormone methylation. Are you familiar with methylation pathways? Thought you might be. Good. I'll move on. You don't need me for that. Okay. Typical hormone methylation. So basically, I think breast cancer in particular, it's about the liver, the gut, very much about stress and emotions. Stress drives up cortisol levels. Cortisol drives up glucose levels. So, it's as important to deal with stress with people as it is to get them eating broccoli or anything like that. The toxic exposure, people can't live in a bubble. So what I, focus on is, let's see if we can sort the liver out, sort the gut out, get the body working properly, rather than sort of say you've got to avoid everything, because that, avoiding things it's far too stressful and expensive. And as you know, poor methylation leads to toxicity. And particularly if the liver toxicity pathways aren't working, they may well have a lifetime of toxicity. And that's ever so is significant with this cancer. Triple negative, it's very significant with. So lots of supplements promote methylation, which is very good. And liver support. Oh, I've done that one, sorry. Ignore that. There we go. So lots of different things that will support the liver and help that. And in good health, coffee enemas can be quite good. And cortisol, I've just mentioned. Prolonged stress alters the effectiveness of cortisol to regulate inflammation. So that is a large inflammatory control. And so, when there's nothing more stressful than being diagnosed with cancer, and then we sort of say, well, you don't want stress and cortisol, do you? So we've got to come in heavy on the anti-inflammatory side and help them with that. And also for helping deal with stress, Siberian ginseng, 5-HTP, normalises serotonin, L-theanine, green tea is very good for that, and adrenal support always.
Would other adaptogens fit in the same?
Yeah, I say it's not exhaustive. I'm sure you come up with lots, but it's just the principle, the principles, and it's looking at really what to do with the person at that time, and not to, some of my clients I think would have me do, oh, you haven't told me to take this, you haven't told me to take that, and someone else has told me to take something else. I'll say, no, we're doing this now. Then we'll come on to that. Just to calm it down. That's just a bit on T cells and cholesterol. And aromatase inhibitors, which are the other type of hormone treatments, again, 20% will become non-compliant, and about 30% at 3 years won't be. And one of the things, aromatase inhibitors such as Arimidex, massive joint inflammation. Not unusual people say, I can barely get up the stairs, I ache and ache and ache so much. And as I say, if you've given that to someone who tends to be used post-menopausal, but you've got someone who's 55, and they're suddenly thinking, God, I'm struggling to climb the stairs and I ache all over. That is no life at all. So these are just a quick list of, and I might just fit cachexia in ever so fast. Oh, I've got triple negative, sorry. Okay. Diet. Oh, diet and cancer. Isn't it contradictory? Generally, what we know, is to minimise dairy, minimise red meat, or cut it out altogether, preferably. Sugar's always out. Natural vegetables, high in fatty acids, and water filter with hormonal breast cancer, and with a lot of cancers, to be honest. I know we haven't got time to touch on it. The ketogenic diet is very popular. and is proving to be interesting and challenging at the same time in terms of people doing it and our feelings on it. It certainly works. Just to briefly touch on it, it certainly works. Whether it's a good long-term strategy or not, I don't know. I worry about cholesterol and things.
It's not advice for prostate or melanoma though, is it? The triglyceride driven.
That's right. Yeah, exactly that. So, and we don't, as we've come along and we've said, we've discovered that prostate cancer, uses fats and triglycerides, etc. That wasn't known a while ago, and people might have been encouraged to do ketogenic, and we're doing the wrong thing. So, yeah, it is a bit of a kind of thing. A lot of clinics use it, and I think, along with fasting, ketogenic, certainly. I was talking to an American doctor the other day. She was madly keen on ketogenic. She wanted this person to just be in complete ketosis all the time, but she's American. And I can't work out the balance yet. I'm currently thinking during treatment, potentially helpful, exposes the cells, anything that reduces glucose, etc. After treatment, is it healthy long term? I'm not convinced yet. Quick look at triple negative. So, in contrast, triple negative has much higher levels of inflammation and hypoxia. And the mutation of cells means hormone receptors have been jettisoned. So, what this means, this is the difference. These cells are, triple negatives tend to be quite small tumours. And these cells are actually mutating at a very fast rate. So, their ability to influence the body and change it and make that environment for themselves is much, much stronger than other types of cancer. So we have to be much, much more, on it, as it were. And what they actually do is triple negative because the three receptors, estrogen, progesterone, and HER2, the cells have changed. They've actually jettisoned the receptors. They don't need them anymore. They are independent of all those things. And they use inflammation much stronger than hormonal breast cancer. So they encourage their androgenic elements. And the reason for this is the XPB1 gene, which is very common with triple negative. And this gene promotes tumour cell survival. And I think, we'll probably find that this is true of other types of cancer like esophageal or pancreatic. And it's also an immune suppressant. And XPB1 gene actually thrives in low oxygen, really thrives in it. So inflammation and low oxygen, you've got very happy triple negative breast cells. And it can turn off the immune function. So all the things we've talked about, we have to be at it 10 times more with triple negative. But because it's very angiogenic, because of that, that's a bit of an Achilles heel. Because if you use chelation with a triple negative breast cancer, you can have a massive effect. If you take away its ability to use angiogenesis, and the studies in America, they used a drug, of course, putting people into remission for 6-7 years. Over here, that's a dream. But you put chelation in, and you be very proactive with it, and don't allow... Cancer cells actually are so clever, they produce their own copper. It's not about circulating copper in the body. They'll actually produce their own copper for angiogenesis. So if we constantly chelate, we will have a big effect on that. And that's just there about the how copper actually has a role in angiogenesis. And again, it affects the vascular endothelial growth factor. It's actually more effective than Avastin. It's more effective. Avastin's the only drug that they have to stop angiogenesis, and vegetables are natural chelators. They naturally chelate, and it's one of the reasons why triple negative. I don't particularly want someone with triple negative going onto a ketogenic diet, because you want that natural chelation from the vegetables and the juicing, etc. We've got lots of chelation agents: zeolite, hexaphosphate, citrus pectins, resveratrol. And you would proportionally want that to be a larger part of your program than just immune stimulation. How are we doing on time? Right, do you want to do questions, or can I do cachexia? Or no, it's too big a subject. Or shall I do cachexia?
Yeah.
All right.
Yes, please.
Okay. I'll just slip through ovarian. Right. Okay, cachexia. Cachexia, because this covers a lot of cancers. Cachexia is something that drives me mad. I used to lecture on this in the NHS many years ago, and nobody knew what I was talking about because it's nutrition, so they weren't interested. Cachexia is the wasting process that takes place when people with cancer lose weight very significantly, very fast. And it pertains to certain types of cancer only. You will not get somebody with triple negative breast cancer with prostate cancer become cachexic. They don't get it. In fact, I often get people, I've got a few people with breast cancer say to me, when do I start to lose weight? You're not going to. Sorry. Bugger. So we can get some benefit from it. Certain types of cancer. So the cancers that do are the lung cancers, gastric cancer, pancreatic cancer as very early stage. Other cancers could kick into it later on, but it's a real vicious circle. And as nutritionists, it's enormously challenging because it's a syndrome consisting of lots of different symptoms, and anorexia, neurasthenia, which is neurasthenia is exhaustion, physical and mental exhaustion. Anorexia, you know. And basically what happens is this process starts to affect the person's ability to eat. So they start to lose their appetite, they start to get what you call early satiety, so they feel full very, sorry, you know this, sorry. They feel full very quickly, which is tremendously distressing for caregivers. You know, if someone's losing weight, they're losing energy, and they say, I made him a really nice meal, I put it down in front of him, he didn't even try. And then they start to get other things, they start to react to smells, things they like to eat before, they can't eat anymore. And this is the symptoms of anorexia. And this is what this brings to people. And it's a real vicious circle because what happens is the metabolization of protein increases, and as they need more, they're actually able to eat less. And often people don't understand what's happening. And what's interesting, what I find very interesting, it's not necessarily related to tumour growth. People always imagine if someone's losing weight like that, that the cancer's really excessive. Go back to Michael Douglas. He was quite cachexic, but it wasn't due to cancer. It was due to that. When you treat head and neck, you get cachexic. And I used to work on a burns unit, and a lot of our severely burnt people got cachexic through shock, I don't know, whatever. So it's not necessarily related to that, but if cachexia is allowed to progress, they're not able to stand having treatments, whether it's complementary treatment or chemotherapy. They won't be able to cope with it. So it's very important, and actually with the right processes, cachexia can be prevented and can be treated as well. Sorry, that's the wrong one. That was the ovarian cancer bit out of sequence here. So this is the typical thing that you see with cachexia, that you see to the muscle mass there. You get a large loss of muscle mass from a fairly well-built person. Just for scientific purposes, this is abnormal muscle mass, and this is normal muscle tone. Abnormal, normal. Have you got that? Does anybody need me to run through that again? No? Okay. Very, very, very nicely distributed around the body, good proportion. And we'll just take a moment to... It never grows old, does it? Really. Fortunately he does, so there you go. Anyway, right, so... Cachexia, it's not been researched enough. What we do know about it is there's an increased proportionate or disproportionate energy expenditure, and the anabolic and catabolic balance in the body goes out, so they become more catabolic. And protein turnover suddenly becomes really, really rapid and accounts for up to 50% of the REE, and also affects the overall oxygen consumption. A massive catabolic process going off in the body, and it's to do with insulin responses and low insulin and leptin levels, etc. So you've got somebody who, can't even get in enough food intake to maintain themselves. And it's frightening when they're losing weight like that. And so we get oxidative stress in the body, raised inflammation again, disturbances. There's mitochondrial disruption in the way that the energy process in the cell takes place. And there's liver stress and lipid metabolization dysfunction. So what happens with someone like this is that the fat lipids that should be circulating in the body start to store in the liver. And that then gives the person a fatty liver. You test your clients for fatty livers, so many of them will have fatty livers. And of course, if they're on chemotherapy, that has a massive effect on the body. But also because the liver generates so much energy, that affects them tremendously. So, and this is the kind of weight loss you get with advanced pancreatic cancer, massive amounts over in a relatively short space of time. And there's a new word. Paradox. Lovely. It's a paradox, just for anybody who's interested. So the paradox we have is glutamine deprivation, and this is a big issue, really, because cancer cells metabolize glucose and they metabolize glutamine. So most of the time with cancer, you would say, okay, let's restrict glutamine going into the patient. Let's make sure that they're not eating glutamine-rich foods. I appreciate glutamine is in just so many food sources, it's impossible, but most people say don't eat protein, don't eat meats, don't eat eggs, go to a vegetarian process. And I have read, cases where they've tried to treat cachexia by glutamine reduction. And I've had this argument with lots of folks over time, because that sounds ideal. And they say, well, you can't give them protein because then that's going to feed the cancer. And that's the argument. But in practice, and this is a matter of judgment at any one particular time, if they're losing glutamine from muscle, and that muscle's been broken down, what's going to happen is you're going to lose the patient before you deal with the cancer. Now, it depends. It's all a matter of judgment. If they're not losing an awful lot of muscle, you can certainly restrict and see how that goes. But what we're finding in research, and there's new evidence with pancreatic cancers, is that the cells are actually switching off their glutamine effect. So pancreatic cancer cells are immune to starvation. So you can deprive them of glutamine. Two things will happen. They'll either take glutamine from the muscles readily until there's hardly anything left of the person, or they'll just switch over, because these are the types of cancers that are very good at evolving. So we have to judge, should we reduce glutamine or not, or should we give glutamine so that the body's getting plenty because the cancer's going to be doing what it likes anyway. And as I say, it can be an anomaly because it may not be cancer related. It may not be a massively active cancer. So there's a lot that's misunderstood about this. But one of the most useful things is metformin, because metformin can affect the mitochondria where the energy comes from, and it can affect the glutamine metabolization as well. So I'd always want now to get somebody on metformin, because it's going to block the glucose and affect glutamine metabolization and hopefully stop that. So what we need to do is we need to monitor, and creatinine measurements when they get the full blood count by the doctors, creatinine will obviously go up when someone's cachexic. Monitor their appetite, monitor the muscle mass, and be flexible when you're dealing with people. It comes with experience, and sometimes if someone's eating very little indeed, it can be a case of it's more important what goes in than what gets left out. It's not. I've seen people literally starve themselves to death, and that's not a good thing. So that's a counter argument. You can read that in your own time. And we're finding things like colon carcinoma cells don't innately show high levels of CYMC, so they don't die when glutamine's deprived. So don't always assume that that's the case. I personally prefer to make sure my clients are getting plenty of protein. And there's a lot of psychology to this as well, because of the anorexic problem, that you need to give very small amounts. It'll switch off if they don't want to. So lots of things into smoothies, lots of liquids and tinctures wherever possible, high-dose amino acids, and lots and lots of liver support. I think we're going to have to stop there, aren't we? Yes. Sorry. Okay, finished. Almost. No, I'm going on.
Thank you so much, Patricia, for a very informative talk. You've given everyone in the room
It's
some
hot
real
in here,
hope.
isn't it?
Some real hope about dealing with oncology patients
Yeah.
with natural therapies. Thank you so much.
My pleasure.